Good afternoon, distinguished colleagues. Today, like in many previous times, we are online with you. And today we're having a webinar that would be devoted to the multiple sclerosis and the challenges with these patients with COVID-19, because we know this pandemic that we faced strongly influenced our behavior. And the specificity of this webinar is that besides two speakers that you know very well, this is Professor Natalia Khachanova and myself, Professor Maria Davidovskaya. Today with us, we will have a dedicated speaker and today global expert in multiple sclerosis. Today we have a dedicated participant, Celia Oreiro Guevara from the Neurological Clinic of Madrid, and she will speak about their experience of managing these patients, keeping in mind their own situation, keeping in mind the specificity that they have, because in Madrid, in Spain, currently they have a very prevalent form of the disease. She represents the Hospital Clínica San Carlos Madrid. So, and I will be the first to speak today. And I would appreciate if all our audience is active enough. And please provide your question, comments, remarks in the web chat. And it's better if you address this question to a particular speaker, and if you name yourself, if the quality of sound is good. So let me start my presentation, and I'm going to share my slides with you. In my first presentation, we will speak about the overview of COVID-19 and immune response. So this is what we know by now. Yes, you understand that the data is changing very fast, but we mainly speak about what is going on and what we already know. I appreciate some help how to switch my slides. Well, the main hero of our story today is new type of coronavirus, SARS-CoV-2. Here you can appreciate the shape of the virus, and this is positive polar one chain RNA virus, and the appearance looks like corona. That's why this type of viruses was called coronavirus. So this is positive polar one chain RNA virus. So normally coronaviruses, they cause typical coronavirus associated diseases, and normally neurologists are not dealing with them, because these are infections of the upper respiratory ways, and we neurologists, we normally don't deal with these diseases, because these are patients with normal immunity who tolerate them very nicely, and only in patients with severe diseases like multiple sclerosis we can see more severe course of the disease. But among typical coronaviruses, there are other coronaviruses shown here at the bottom of the slide. You can appreciate that currently there are 3 of them. We already witnessed 2 epidemics, and the third one is current one, which is SARS-CoV-2 epidemic, because we already faced severe acute respiratory syndrome epidemic and Middle East respiratory syndrome, SARS and MERS, and now this is SARS-CoV-2. But all in all, we see that 2% of the population are just healthy carriers, and coronaviruses are responsible for 10% of all acute respiratory viral infections. On this slide, you can appreciate the data which is changing daily. So this is daily changing information. So this is how you track online the dashboard of the virus, which is provided by the Center for Systemic Science and Engineering. This is how COVID is spreading around, but definitely this slide is currently outdated. We know that now this is more than 2 million infected people all over the world, and number one in the number of infected persons is United States, then Spain is number two, then Italy, France, Germany, and Russia is taking position number 15, or maybe is closing to top 10. So this is Russian data by April 21st. So we entered pandemic a bit later. So with a delay, so totally we have about 52,000 infected cases, but almost daily we are increasing plus 5,000, plus 3,000. Well, there are patients who are cured and there are some fatalities. So currently we have about 500 fatalities. So unlike other countries that I mentioned before, Russia is at the very beginning of viral exponential growth, and in the further days we are also expecting the growth number of infected persons. And this slide, I want to simply show you that all our life is anyway related with these balls, colorful balls, these viruses, these bacteria. So we are facing them lifelong, and actually they changed the history of humanity and then influenced us very strongly. So we remember that in Middle Ages there were very severe pandemics of plague. In the 17th and 18th century, there were 3 pandemics of cholera, then yellow fever, influenza, so-called Spanish influenza, and at the beginning of the 19th century, that was again Spanish type of flu, Spanish type of influenza that led to huge mortality all over the world, killing more than 2 million people at that time. And it changed the medical care at that time. Then we faced HIV and AIDS, and definitely it is yet still quite a challenging issue. And finally, we're facing new heroes, SARS virus, and yet believe me, the ball is very small versus other balls with other viruses and other pandemics. But this is just the beginning of the story, and we yet do not know what could be the outcome, what could be the future. So currently we are here in the outburst of pandemic. So in the level of mortality and the level of infectiveness. So infectiveness, contagiousness is axis X, and fatality is axis Y. So COVID is not highest in mortality. If you look at SARS or MERS, well, COVID is not as mortal and fatal as it could be. And even looking at the contagiousness, it's different from measles, for example, and from chickenpox and mumps. That's why it's somewhere in the middle. And majority of the population that are infected by COVID-19 are having it either asymptomatic completely or in a very mild form. This is data April 14, 2020, and this is New York City health data. You can appreciate that if you take the age from 0 to 17 years old, just 3 deaths, which is 0.04% from the total statistics, and they all had comorbidities. Then age group 18 to 44, so total number of deaths is 309. And then majority of them, 244, also had some comorbidities. And that is why it was a worsening factor leading to the fatal outcome. The age group 45 to 64, here we see 5-time higher rates. And the total number in statistics is 23%. And here we can appreciate comorbidities and without comorbidities. So we see different patients here, but mainly definitely patients with comorbidities are leading here. Then age group 65 to 74, Well, about 1,600 deaths, which is 24% from the total data, and mainly patients with comorbidities as well. And 75 plus, this is the highest mortality rate. This is a rate which is the highest, and this is leading number of deaths. This is 47%, and from them, vast majority had some comorbidities. Among comorbidities, we can identify the following important ones. They could increase the severity of the infection. This is diabetes mellitus, diabetes type 2, respiratory diseases, oncological diseases, different type of immunodeficiencies, including immunodeficiencies with particular drugs or drug-associated immunodeficiencies, then arterial hypertension, asthma, cardiovascular diseases, renal diseases, and GI tract diseases, gastrointestinal diseases. Well, we have temporary guidelines for the diagnosis and prevention of COVID-19, which were published by the Ministry of Health of the Russian Federation. And we already have description of suspicious cases and confirmed cases. And this is version 4 of temporary guidelines of the Ministry of Health of the Russian Federation. They are published on the website. So suspicious, if the case, which has manifestation of acute bronchitis, pneumonia, ARDS, sepsis, in combination with epidemiological medical history. Epidemiological history, which makes this patient suspicious for COVID, is a return from abroad 14 days before or earlier, then close contact with COVID positive people for the last 14 days, and also close contacts for the last 14 days with those persons where there was a laboratory positive COVID-19 test. We have to say that unfortunately we used to wait for this test for days and hours, but now we have daily massive testing and very active clinical observation. So now we have quite extended test profile. A positive test, it's a positive lab result, presence of RNA of SARS-CoV-2 by PCR, no matter of clinical picture. It could be zero clinical manifestation, but positive test, then this positive is confirmed COVID. And also COVID-19 is considered to be potentially severe acute respiratory infection, which is caused by SARS-CoV-2 virus. So according to the gradation, this is potentially severe acute respiratory viral infection. Besides, there are guidelines for the diagnosis of COVID-19. And here you can appreciate that the diagnosis is made based upon clinical picture of the patient, epidemiological data of the patient, plus lab tests. So, and the main one here are CT of the lung. And here you see CT data. I think the majority of hospitals in Moscow and Moscow region, they're using CT for the primary diagnosis, because yet test is not quite reliable. And the other method is ECG. Because from the clinical picture, this is complaints, analysis of signs and features, epidemiological history, which I already mentioned before. Then physical examination includes thermometry and also consciousness, measurement of respiratory rate, heart rate, then assessment of mucosa of the upper respiratory way, auscultation, percussion, and lymph nodes examination, abdominal test, and measurement of liver and spleen, and laboratory diagnosis, which includes total blood count, biochemical blood tests, C-reactive protein, D-dimer, patients with respiratory failure, we require test of gases of blood, arterial blood, coagulogram, and also what is essential is to identify RNA SARS-CoV-2 by PCR. Hospitalization today. is done according to the order of the Ministry of Health of the Russian Federation from March 19, 2020. This is the number of the order about the temporary order to hospitalize patients to prevent and reduce mortality from COVID-19. You know that in Moscow city, many hospitals were completely transformed into COVID-based clinics. And this is definitely temporarily, as we hope. By now, what we know, incubation period takes from 2 to 14 days. COVID-19 can be mild and severe. Then patients discharged with laboratory confirmed diagnosis COVID-19 is allowed if there are no clinical manifestations of the disease and there are two negative tests, lab tests on the RNA of this virus presence via PCR with the interval at least 24 hours in between two tests. So there should be not single but double negative with the interval of 24 hours and the absence of clinical manifestation of the patient. Clinical manifestation, which I mentioned before. This is not specific, unfortunately, but even here, we can identify some specific things that, let's say, more characteristic for this type of the disease. Well, increased temperature, running temperature in more than 90% of the patients, then 80%, 80, dry cough with a little bit of sputum. And normally cough starts very soon. Then 55% of the patients demonstrate dyspnoea. The most severe dyspnoea normally develops at day 6 to 8 from the day of infection. Then what is typical is myalgia, fatigue, and about 20% have chest tightness, which is not typical, by the way, for the respiratory infections. Chest tightness is quite a specific symptom, I would say here, and this is specific for this disease. Clinical manifestations, it's either pneumonia or DS, sepsis, or septic shock. And what we see here, it could be three scenarios. It could be mild scenario, which is about 81%, then severe, type severe cause, it's 14 cases, and critical forms with a very fast development of polyorganic failure and sepsis. These are about 5% of all the cases. Most frequent laboratory characteristics that allow us to suspect the virus as fast as possible and to suspect it. First of all, this is lung CT. And here we see the typical picture. This is infiltration from one or both sides, normally bilateral, and about 40% of changes on the X-rays away. Then positive troponin tests, up to 12% of the cases. And then severity on this picture gives us worsened prognosis. Besides, patients from 22 to 38% of cases demonstrate increased liver enzymes, ALT, AST increased in about 30% of cases, but this is not quite specific. We don't know exactly how frequent it could be. Lymphopenia, 32 to 38%. And also we have to say that the severity of lymphopenia, again, is associated with the severity of the virus itself and option to restore the patient to recover. Then LDH increased in quite a number of cases. Then again, severity is associated with the disease, and also we see positive procalcitonin tests. And the increase of procalcitonin is seen in less than 10% of the cases, and possibly it also provides some influence, but it requires further studies. We're not quite confident about that. So this lab characteristics is about to be studied in the future. So here you see some general slide. This is a typical development of any acute infection when in the organism there is particular pathogenic agent, and we see infection, development, presentation of antigen, and then infection induction, then the development of adaptive response with further elimination of this antigen and the development of adaptive immune response. So from innate immune response, then we switch to adaptive immune response. So in this case, well, yet not all the questions answered here, but we believe that this virus, SARS-CoV-2, is phagocyte-presenting antigen cells due to neutrophils, and NK cells, in their turn, activate complement, system of complement. And this is huge cytokine response, IL-16 specifically, IL-6, apologizes the speaker. And then you see how other pro-inflammatory cytokines are involved. We see CD8 cells, then proliferation of CD8, and finally activation of B cells by CD40 helpers. And they're actively involved into the process of this virus elimination. Normally, we can recognize several types of responses to coronavirus. First, it's protective immune regulation, and as a result of influence immune cells, interaction immune cell with agonism, it creates to the protective immunity. When we face particular virus, there is development of early interferon response. So there is infection of neutrophils, and then it leads to the release of pro-inflammatory cytokines, which I mentioned before, including IL-6. In the cases of protective immune regulation, it leads to the minimal apoptosis of epithelial and endothelial cells, so increased permeability of the vessels, optimal anti-cell antibody response, and effective viral clearance. So that means we are self-resolving. We eliminate the virus due to the immune system, and as a result, we develop protective immunity. But in pathological cases or in the cases of dysregulation of the immune response, and this is exactly what can be seen in the elderly population and in patients with different comorbidities, and patients with increased sensitivity with this specific coronavirus. So in their case, this pathological chain is dysregulated. So what we see is burst-like replication of a virus. It's much higher what we see normally, and interferon response is not sufficient enough or not fast enough to respond to this viral attack. There is multiple infiltration of monocytes, neutrophils, and monocytes in this area. And then finally, we see the release and the production of huge cascade of pro-inflammatory cytokines. Well, pro-inflammatory cytokines, they're active cells. They're causing a very big effect of endothelial and epithelial cells, permeability of the vessels, then suboptimal T cell antibody response on non-effective virus clearance. So that means standard activity of immune system, interferon-based response is not sufficient enough, and there is no effective clearance of the virus, but the infection itself is switching into severe forms, into severe types, including ARDS or ARF, acute respiratory failure. The circulation of immune response. We know what influences that. What we saw in less severe cases and in more severe cases, and what differentiates them from each other. First of all, lymphocyte level. So this is normal level, 20 to 50. So, but in severe patients, normally This is lymphopenia. And unlike non-severe patients, you see here they are close to the normal level. Also, researchers managed to see how neutrophils lymphocyte ratio is changed, and they're very different. You see that this is 5.5 in severe patients, neutrophils to lymphocyte ratio 5.5 in severe and 3.2 in non-severe. Then CD3, CD19 T cells. And this is normal range. First column is normal range up to 3000, and then dramatic reductions. So they're dropping down, almost no T cells in severe patients and even in non-severe patients. So sort of an average reduction in those severe patients. So this is not such high statistical difference. And very clear difference in the level of IL-6. So normally it's up to 7, not higher than 7, but in severe cases, IL-6 is 25 picogram per microliter, and twice less in non-severe patients, about 13. So this is statistically significant difference. P-value is less than 0.001. So this is sort of a dysregulation, and in some patients we already immunologically can suspect that COVID-19 will be very severe. So these are the patients who have increased ratio of neutrophils to lymphocytes. Then patients with chronic lymphopenia, pre-existing or developed as a result of infection, and patients with increased level of IL-6. Definitely, we can clearly understand that our patients, MS patients, and also those patients who are getting immunomodulating treatment, so vast majority of them do have these features of immune response dysregulation. By now, there was offered the concept of so-called cytokine storm. There is a dysregulation, as I said before, of immune response and massive release of pro-inflammatory cytokines. And there is dramatic increase of immunological cells, and different cytokines and chemokines are released, specifically IL-6 and others, which are presented here. And on the other hand, this concept has not yet been proved completely, but at the same time, it gives us an opportunity to start studying different methods and approaches to treatment. First of all, interferon-based treatment, then corticosteroid treatment, IV immunoglobulins, IVIG, so I mean high dose intravenous immunoglobulins, also drugs that can suppress IL-6 release, and different inhibitors that are already available. Anti-IL-6 that are normally used for other indications, also TNF-alpha inhibitors possibly, and some other possible mechanisms and blockers shown here, including siponimod, that is having totally different indication initially, but under current conditions and with the help of further studies can possibly be effective in case of COVID-19 as well, especially if the disease is quite severe. As I said before, these are just concepts. These are just concepts that were designed based upon very recent data that were started because huge pool of patients and many research groups are working all over the world, and these are possible methods of treatment that naturally just suggestive, so without proper evidence, and some of them are just to be examined in the framework of some clinical trials in COVID-19 scenario. So that's it, what I wanted to say for today. So thank you very much for your attention. And if you have any questions, comments, remarks, you're welcome. I'm ready to respond. If yet we do not have any questions, we can have discussion at the end of all three presentations. So, right, what do you think? And now I'm happy to give the floor to the next speaker. And this is our Spanish guest from Madrid, Professor Celia Araya Guevara. The floor is yours. You're welcome.
Thank you. So first, I would like to thank Professor Cajanova for the kind introduction. And I would like to thank Roche and Marina Gafarova for the invitation to speak today for the neurologists in Russia. For me, it's a pleasure to speak today with Russia in this virtual chat. I will explain my experience in Spain. So as you have seen, Professor, I think I say right, but I am not sure. I cannot speak Russian. Professor Cajanova, I have shown that Spain is the country with this is the second in the is the second country with most infected people and most death. So that I will explain how is our experience. That are my disclosures. So first, I will explain Spain. What is the situation in Spain? That is far from Russia now. Later, the situation in Madrid, and later, how is the situation in our hospital, and how we have managed everything to try to help our patients. So first, for the situation in Spain, we have 46 million inhabitants in Spain, and we have now, as Professor Cajanova said, the numbers are changing every day. So that now we have in Spain today 220,000 infected people. So that is a lot. That is more than 200,000 people infected. When we look in Madrid, Madrid is 6 million inhabitants. And today we have more infected people than in Russia together. So we have in Madrid today 62,000 infected people. So there is a lot. That is, as I have showed your numbers before. So that is more than in the whole Russia today. So that the first patient that I think an important thing is to when to close the country and when to do all the things, how to manage the situation earlier enough to avoid to have many patients infected. So our first patient was in January, 29th of January. That was a German coming to the Canary Islands. And we thought it's not very bad. It's only one person in Canary Islands. It's a German, and we were not doing anything. So later we have the second patient was in Mallorca, and we are not very worried about, but the situation was growing and growing, so that we have the alarm state in Madrid 10th of May, the 10th of March 2022, and we closed Spain. So the alarm state in Spain was 14/3/22. So what means this? It means the people they must be at home. They can only go out for the pharmacy, for going shopping, food shopping, going to the doctor, and only the people that they have a very very important essential job like hospitals, pharmacies, for example, petrol to give petrol for the cars. These people they can work. The rest of the people in Spain they cannot work. They must stay at home. Otherwise, we will have a lot of infected people, and we cannot treat so many people. The problem is you cannot treat so many people in very few days. That is the big problem. So that is the situation in Spain. As you see here, that was only some days ago. It's only from less than 1 week ago. And the situation only to show you that the most of the infected in Madrid are in Madrid. That is the problem because everybody is concentrated in Madrid. And as I told before, we are now 62,000 people infected in Madrid, so more than in the whole Russia. The second place is Catalonia, Barcelona, and later the other places they have much less than in the two big cities. Before, Professor Cajanova has shown with the death, with the mortality, and here is the same like in New York. The most of the people that they have died, they are people that they are older, as you can see, and the most of them they are men. You see here there are more men than women, and the most of them they start the deaths with 60, with 70 is a lot, and the patients with 80, they are the patients they have more deaths. And when we look at the infections are more or less similar for women and for men. So for death is more for men. For the infections is very similar, more men and women. And as you see, the most of the infected are people between 40 and 70. That is the people that they are working, that they are moving more. So they're the people that they are more infected. So here is only that you see which was the number here. That was the worst moment of our epidemic. That was now 20 days ago. That was the moment that our hospital, they were completely full. The previous speaker was saying that some hospitals are transforming in COVID hospitals. So at the beginning, we have transforming COVID hospitals only 2 or 3, and at the end, they were all the hospitals in Madrid. Because you see here, that was the most important moment, and there were a lot of patients that was in Madrid only because the things are very fast and the numbers are very, very fast. As you see here, that was 2 weeks ago, 20 days ago, and there were 24 in Madrid, and now are 62. So now are 3 times more in 3 weeks. So that really the numbers are very high. And you see here that is only 1 week ago, and you see here that is the double. So here in 2 weeks, you have the double number of infected and the double number of deaths. So that's really that is very important to take measurements very fast because the numbers are very high. And here is the demonstration. We thought at the beginning is we can do some COVID hospitals, perhaps some hospitals with COVID and other hospitals without. But at the end, the numbers they were so high in Madrid and they increased so fast that at the end all the hospitals in Madrid they were COVID hospitals. You can see here they are all the hospitals in Madrid. We are 6 million inhabitants, and all of them they were full of COVID patients, full of COVID patients. They were not possible to have other patients, only coronavirus patients. That is my hospital, and that was in this day of March. That was around 700, but there was one day that we were around 1,000 patients with coronavirus. There were only 2 or 3 with a stroke, some patients with heart infarct, some patients with emergency surgery, and that was no more. That was completely full of patients with coronavirus. And as you see here, we say in January, but in March there was very fast, and we took until 60. That was in Madrid, 60,000 in the hospitals. You can imagine 60,000 patients at the same time in all the hospitals in Madrid. And from then we have 1,500 patients in the unit care. So and here is later. So that is the date of this week. That was 21 of this week. So that is only 3 days ago. And you see here now the numbers are relative much better. As you can see here, that was in March. In March, we have until 60,000 patients in hospital in Madrid. And now you see we have only 7,000. So that we have reduced the half of our patients in the hospital. But you see here was the big problem in Madrid, and what you see 8th of March was the big problem. There was a big demonstration, a lot of football match, concert, and many things. As you see, 3 weeks later, that was the high increase. And we have taken the measurement to close everybody that was here, and we have need 3 weeks until the curve was decreasing, so that when you take measurement, you need 2 weeks that you can see that the numbers of the infections, they are decreasing. So that is a very important thing when you are taking measurement, because you think that it's not so fast that you have the numbers decreasing. So, and that is in Madrid. So that, as I told before, all the hospitals in Madrid at the end, they were COVID hospitals because there were no more place. And we have done, like in China, a hospital. We have a big fair trade building. And we have done a hospital outside from Madrid in this trade building for 6,000 patients, because we were not possible to take more patients in the hospital. So that we have done in 1 week a new hospital in a very big place, very big building of the mess of the fair trade, that they do always mobile trade and other things. And we have done there 5,000 patients to help the other hospitals. So that is my hospital. My hospital is a university hospital. We have a university, that is the University Complutense, that is the oldest university in Madrid. And as you see, we have normally 700 beds, but was one day that we have 1,000 patients with coronavirus, because we put beds everywhere, in every place of the hospitals, every place where there was a place to put, we have put beds and we have put oxygen together, so that we were looking for every free place to put patients. We have 53 departments, and the worst days of the coronavirus pandemic, we have only coronavirus, stroke, heart infarct, gynecologists, and surgery, emergent surgery, and no more. So only 5 of these 53 medical departments. And that is our MS Center. Our MS Center, we are treating around 1,700 patients. And from these patients, we have 1,450 patients that they are treated with a disease-modifying treatment. And we have only 46 patients with NMO. NMO is not very common in Spain. Our patients, I don't know how is the system in Russia. Our patients are all of them treated in hospitals. We don't treat the patients outside from the hospital. The MS patients, they are coming in the hospitals because in the hospitals they pick up the medication and the medication is free for them, so that they need always to come to the hospitals, and we treat these patients always in the hospitals, and we visit the patients in the hospitals. And we have a day hospital, and in this day hospital, inside the hospital, we give all the treatments like natalizumab or ocrelizumab, all the IV treatments that we give in the daily hospital that is inside the hospital, so that all the MS patients, they need always to go to a hospital. We don't never treat the patients by the GPs or by the outside consultation. They are always in the hospitals. So that when you see that we have at the beginning, we have now our hospital is a COVID hospital. So the problem is our hospital has a very high risk of infection because all the patients are inside with coronavirus. Many physicians are infected. Now in Spain, there are 30,000 physicians infected, and there are 6,000 physicians infected in Madrid. So that you can imagine the high infections that they are in the hospital, so that we have decided we cannot have our MS patients in the hospital because the risk of infection was very high. So that what we have done before the alarm state in Madrid, we have closed all the consultations. We have no more consultations for MS patients. The ambulatory patients, they were not allowed to come to the hospital because in the hospital there were increasing number of coronavirus patients. We have the only thing that we have open was the day clinic because we wanted to have our patients with ocrelizumab, natalizumab. We wanted to treat them. So in particular, the patients with Tisabri, you cannot leave a patient with natalizumab 8 weeks without anything because later they will have a rebound or a relapse. So that the day hospital was the only thing that was open for our patients. The hospital pharmacy was open and to give the patients. And the neurology ward, they were closed, completely closed. We have only 4 beds for a stroke, and the neurology was disappeared, like the whole other departments. And the neurologists, what we have done, the neurologists. So the hospital have decided to put the young neurologists working by the coronavirus, the older neurologists working outside from the hospital in another building far away, and that was a clean building. And in this clean building, they were treated. They were treated patients, neurologist patients that they were with some emergency, for example, a relapse of MS, problems with myasthenia gravis, and they were treated in another building outside from the hospital, so 10 minutes far away from the hospital, and that was a clean hospital, and they were there 3 neurologists treating all the emergencies for the neurology. And there were the 3 neurologists for the stroke, and the other neurologists, we were doing only telephonic consultation. We were calling our patient, we were doing video conference, we were doing Zoom to try to help our patients. So that every day we were doing telephone consultations to our patients. The communication with our patients was by telephone, by email, and through the nurses. The nurses, they changed the place in the hospital, but they were taking the same, we're having the same telephone number. It was very important to have a very narrow relation with the association of patients the association of patients, they were calling us with a lot of questions from our patients, and that was very important because they have more, they could reach more patients than we, so that the associations, they were calling us to say we have a patient with coronavirus, with MS, or we have a patient with a lot of problems. The other important thing was that our hospital pharmacy was sent the medicine, treatment to all the patients. So the important thing was not to have patients in an infected environment, not to have patients in an infected hospital, an infected GP consultation, so that we have decided to send to the patients the medication at home, so that they were at home and they didn't need to move. For the day clinic that was open, we have put the seats very far away, so 2 meters between one seat and the other seat. We have measured fever twice. We have all the patients with mask and gloves, so that we have minimized the infection risk in the daily hospital. With the blood samples, we have done only for the patients that was really an emergency. We have decided not to do blood examination, because for blood examination, they need to come to us or to the GP or to some other place, and all the places with physicians, they were with a lot of infection. So that we have decided only to take blood for really patients that they need, like, for example, to start cladribine, or to have a new cycle of ocrelizumab or something like that, or for a relapse, but only for emergencies. And we have all these emergencies patients with relapses we have sent to this building far away from our hospital. And how, when a patient was with a relapse, we have spoken with them telephonic, or we have seen by video, and we have put the reset by computer, and we have given only oral corticosteroid, because oral they can take at home, they don't need to come to the hospital, they don't need to come to the consultation. So that our objective was always to have all our patients at home to avoid the infection. So what is the thing with the patients? Our patients, they were very, very worried. They knew that they cannot come to the consultations. They were very scared because they thought, okay, when I am taking an immunosuppressive drug, I am immunosuppressive, perhaps I will have coronavirus and perhaps I will die. So that they were very worried at the beginning of the pandemic, and they were calling us a lot. They were calling the physicians, they were calling the nurse, they were calling the associations. So that the first 3 weeks, we have a lot of calls, so more than in our whole life, because all the patients, they were very worried, they were always asking things. One problem that was that some patients, they have decided to stop the treatments, because television was saying patients with immunosuppressive treatments, they are in danger, because they are in risk, because they are with less lymphocytes. So that some patients, they have decided to stop the treatments, and we were calling these patients to start again the treatments. And as I said before, they were always asking for information because they were very worried about everything. How was with the therapies? How we have decided? We have decided to keep patients with interferon and glitamic acetate because there are no risk. And you know that there are some trials with interferon in patients with coronavirus. With teriflunomide, we have keep teriflunomide, the patients they were, but we have some patients with coronavirus with Auvallo, and only with these patients with coronavirus and with Auvallo, they have less lymphocytes. We have stopped Auvallo for 1 or 2 weeks, and later we have start again. And there was the same for patients with dimethyl fumarate. We have some patients with dimethyl fumarate, and they were with COVID. And only when they have less lymphopenia, when they have less lymphocyte, we have stopped Tefidera. Otherwise, when the lymphocyte they were in the normal level, we didn't have stop Tecfidera. The same for Auvallo. Only patients with a less lymphocyte we have stopped Tecfidera or Auvallo. We have for the other treatments, for the high active patients, we have done in another way. We have individualized every case, so that for alemtuzumab, we have no patients now in this period, in these 3 months for alemtuzumab, so that we didn't take some measurements. For natalizumab, we have decided to delay for 4 to 6 the most of the patients, to avoid that the patients are outside from the home, and to avoid that the patients are coming to us or to the GP, so that we have decided to put all the Tisabris in 6 weeks. And only in patients with coronavirus, we have delayed until 8 weeks. I will show you later that we have some patients with Tisabri and coronavirus, and we have delayed until 8 weeks. With fingolimod, we have continued, and we have done the same. Patients with coronavirus and fingolimod, we have stopped when they have very few lymphocytes. After the coronavirus infection, we have started again. With cladribine, we have postponed in some patients the second year because two things, two reasons. One, they have not received the medication at home from the pharmacy at the beginning, because until you organize everything, you need some time. Yeah, you need 1-2 weeks. So that's at the beginning, the patients, they have no the medication at home. They should come to the hospital. So in these 2 weeks was difficult. Later, the patients, they have received the medication so that they could start with cladribine. And the other thing was we could not take blood, as I told you before at the beginning, so that we have delayed some cladribines 2 or 3 weeks until we have the result of the blood test. We have some patients with coronavirus and Mavenclad, and when they have coronavirus and they have a good lymphocyte, we have done anything. And we didn't start MS treatments, new MS treatment in the first 4 weeks because was impossible. That was a logistic problem. Yeah, we didn't want to have the patients in the hospital. We didn't want to have the patients by the GP, by the other neurologists, so that we have decided to delay the new treatments 1 month. And how was with ocrelizumab? With ocrelizumab, we have decided to put 3 groups of patients. So there was one group that was the primary progressive MS patients. These patients, because they are older, and you know that the most of the patients with coronavirus, with COVID, that they are dying now, are patients that they are older. So that normally patients with primary progressive MS, they are older, they have more medications, they have more comorbidities. So that we have decided to postpone these patients. Normally, these patients, they don't have relapses, so that we have decided to postpone the ocrelizumab for 6 weeks until the situation is better. The patients with relapsing MS and with that they were having natalizumab before and they are active patients, we have decided to postpone only 1 or 2 weeks, no more. Only the worst weeks that they were the most coronavirus in the hospital, we didn't put ocrelizumab, but we have delayed only 2 weeks for these patients that they were active and they were coming from Tisabri. And the last group was patients that they were relapsing MS, they were stable, they were not active. We have decided to postpone between 2 and 4 weeks, but not more. Yeah, because the objective was always the same, that the patient should stay at home, not to have the infection. So that was better to delay 2 to 4 weeks for the patients that they were not active. For the active patients was only 2 weeks. And here is our patients infected by coronavirus. That was 19. Today are 21. I have 2 more yesterday. So that, as you see, our patients, most of them, they are relapsing remitting MS. And we have only 1 patient with secondary progressive MS. The reason probably is because the patients with progressive MS, they are really very, very afraid, and they have decided to stay at home, not to go shopping, not to go to the pharmacy, not to go to the doctor, so that they are at home. When we call, they always say, I am at home. My husband is doing everything, or my daughter is doing everything, but they are at home, so that they are not infected. So, and the others, they are infected, they was the relapsing. And from these patients, we have 4 patients that they were hospitalized, and I will tell later about these patients. So, and the most of, as you see, is not very much. There were now 21 patients with MS from the 1,700 patients in a city with a lot of infected patients, so that we realize that the patients with MS, most of them, they are not infected. And when they are infected, they have a very mild course of the disease. That is the good thing. Here you can see the age average. The age average, this is 40, and we have all the, as you see, from 28 to 67. We have always more females as male, like always in the MS. And the disease duration is 10, but it's from 1 to 20, so all the possibilities. The EDSS was 2, but we have from 0 to 4, probably because the progressive MS, as I say to you, the patients with the progressive MS, they have decided to stay always at home, and the most of them, they were relapsing remitting MS. How is with the symptoms? You know that at the beginning they told us the symptoms are always fever and dry cough, but that is not real. There are patients with different symptoms, and we have like 2 groups of patients. There are patients that they have fever dry cough, and and some breathing problems. But there are other patients that they have more fatigue, atem problems, breathing problems, muscle pain, throat pain, so other kind of symptoms. So as you see here, so that the most of our patients, they have reported breathing problems, not always dyspnea, so some breathing problems. They cannot, they need always to take some oxygen. We have the other one that was a fatigue, probably fatigue because the patients with MS, they have always fatigue, and fatigue from MS plus fatigue from COVID, they have more fatigue. And fever, you see the third symptom was fever, and that was dry cough, and later the other ones with pain, throat pain, muscle pain, and we have some patients with anosmia and with diarrhea. So when we look after how is the diagnosis is a problem, as you know, and as in many countries, you know, at the beginning it's very difficult. You cannot do the PCR to everybody because there are not enough tests. There are not enough tests for everybody, so that the people that they have a mild course of the disease of coronavirus, they are not having tests. They have decided, because we have not enough tests for all the patients and for all the infected, we will do first the test for the patients that they have a moderate or severe course, so that we have confirmed 6 cases for PCR. 3 cases we have confirmed because of the X-ray, because when a patient has a fever and has some breathing problems, they have done a X-ray, and when the X-ray was typical for coronavirus, we have confirmed the diagnosis, and we have 10 patients with clinical typical symptoms of coronavirus, with fever, dry cough, with fatigue, with a lot of muscle pain, so that they were typical cases of coronavirus. That they were not typical, we have excluded for the evaluation. When we look at the PCR, you know that the problem with the PCR test is that you have many times false negative, and that is a problem. And so we have 6 patients with they were positive, 3 patients they were negative, and in 10 cases we have no perform. How was with the treatment? So we have all the treatments. So you see here for betaferon, we use a lot of bio. Now we use a lot of oral treatment for the first line, so that we have a lot of bio in our hospital, so that we have 6 patients with bio, 1 with Tefidera, 4 patients with Tisabri. As I told before, in these patients with the Tisabri, when they were with the COVID infection, we were waiting, and most of them they have received the Tisabri or 6 weeks later or 8 weeks later. Only 1 patient was 8 weeks later, and the others they were 6. So that we didn't want it to have more interval between the last one and the next one, that was 8 weeks, but not more. And our experience with the 4 patients with Tisabri is that they have recovered very fast. They were 1 week with ill or 2 weeks ill, and later they have recovered really very, very fast. And they have no lymphopenia, probably because they have a lot of lymphocytes. The patients with the Gilenia, both patients of the Gilenia will have stopped only one of the patients with the Gilenia, because he was with 300 lymphocyte, the other was with 700 lymphocyte. We didn't stop. And with the Mavenclad, the 3 patients with Mavenclad, in one of them, we have delayed the second year. The other two, they were in the middle between the first and the second year, and we have done anything. And the patients with Ocrevus, I will show later. So that in total, from these 19 patients, we have stopped 2 treatments, 1 patient with Gilenia and 1 patient with Aubagio. And we have delayed 6 treatments, so 3 with Mavenclad and 3 with Tisabri. What they have received. So at the beginning, I think that is an advantage for you, because you know more than we have when we start our epidemic in Spain. That was at the beginning of March, and that was very difficult to have information how to treat the patients in general. Now I think that with a lot of publications in April, it's easier now that how to do this. Our patients, as I told before, most of our patients, they have a very mild to moderate course, and most of them, they were treated with paracetamol and other anti-inflammatory drugs. We have 3 patients with antiviral therapy, that was Caletra for the HIV. We have three patients with antibiotic. We have no patients treated with corticosteroid, and we have 5 patients treated with hydroxychloroquine. And here are our 4 patients that they were with that were hospitalized. These 4 patients. One was the patients with the secondary progressive MS. That is a patient that is 65-year-old, so there's an older patient. This patient is always with a lot of urinary infections. This every year at least two times in the hospital because of urinary sepsis every year. So that is a patient that is always with a lot of problems, and we have this patient many times in the hospital because of the urinary sepsis. So that he was hospitalized. She was before with Mavenclad. This patient was with an ADSS of 4. The problems of these patients, they are cognitive problems, and we have treated with hydroxychloroquine, antiviral, Caletra, and cefotaxime. All these patients, the 3 patients, they have received oxygen and they have a pneumonia. All the 4, they have a pneumonia, and that was the reason for the hospitalization. The 2 patients of ocrelizumab, I will explain later. And here was a patient with Aubayo. She was only 3 days in the hospital, and she was treated only with, as you see here, hydroxychloroquine and Caletra. She has a pneumonia, but she was only 3 days in the hospital, and they have sent to home. And these patients with the ocrelizumab, this woman is now at home. She was only 1 week in the hospital, and she has, as you see, she has a comorbidity. She has a lung cancer. And the other patients with ocrelizumab, she was 4 weeks in the hospital. That was the only case that was really bad. That was this patient with the ocrelizumab, and we don't know why. Here is our first patients with the ocrelizumab, and that is this 50-year-old woman. She had a lung cancer, and that was a clear, and a high blood pressure. So she has 2 risk factors, 2 comorbidities, 2 risk factors for the coronavirus. The diagnosis was 2008. She had an relapsing multiple sclerosis, and the EDS was low, 3.5. She has 9 years natalizumab, and we have switched because she has a GC virus positive, very high, suddenly, so that we have decided to switch to ocrelizumab. And we have started ocrelizumab in May 2019, and the last ocrelizumab was 5 months ago, so in November 2019, so that the lymphocyte, they were not so low. She was hospitalized. She was with a pneumonia, and the patient, the physicians from the intensive care unit, they thought she has a lung cancer, she has a hypertension. It's better to have this patient in the hospital. And she was 1 week in the hospital, and she was with fever, with a dry cough, with a muscle pain, diarrhea, and some breathing problems. They have treated with the 3 things: hydroxychloroquine, Caletra, and oxygen. And now she's at home. Now she's 2 weeks at home, and she's completely good. She's again doing everything, and she told me that she will go next week to work again because she's in one of these essential works. That is the second case. That is the only case that was not very good. But now was 4 weeks in the hospital, but now it's at home. That is 34 years old, and the diagnosis was 2012. It's not very far away. She had a relapsing MS. She has a very low EDSS, and he has ocrelizumab from 2013 because he was in the opera study. 2015. So, and the symptoms, they were the same: fever, dry cough, muscle pain, and some breathing dyspnea, and some breathing problems. So this patient has a problem because at the beginning he was a PCR negative. He was with fever, but nobody believed him because the PCR was negative. They repeat again the PCR, and the PCR was again negative. And they thought it's better to stay at home with fever. And the third time was the PCR negative, but they have decided to have in the hospital because they have done a CT thorax, and the CT thorax was a very severe pneumonia, so that he was in the hospital. Probably the problem with this patient that was he was in the hospital too late because of the negative result of the PCR. And as I told before, 30% of they are false negative with the PCR, and that is really a problem with some patients. Now he was 4 weeks in the hospital. He received oxygen, hydroxychloroquine, and azithromycin, and now is everything okay, and he's again at home. And here is the last case. That is not my case. It's a case that was published last week in the multiple sclerosis related disorders. And that was a male, 58 years old, with some comorbidities, asthma, that is an important thing. The diagnosis was 2009, and he has a primary progressive MS. I told before, primary progressive MS, 58 years old, that is always a risk because he was older, and with primary progressive MS, normally these people, they have more comorbidities, as you see, and the EDSS was high, 6. So these patients, they have all the treatments before, and he switched to ocrelizumab because of two factors. And he has ocrelizumab in January 2018. Last time was in summer 2019, and he was hospitalized only for 3 days. He has no pneumonia, only he has this. He had fever, because he had fever, and he was, as you say here, he has fever, had severe dry cough, muscle pain, some breathing problems. They have decided to hospitalize, but he was without pneumonia, and they have only 3 days in the hospital, the same like our Ovajo patients, because many patients, they have breathing alterations. They cannot breathe, but they have no pneumonia. So they have other problems, but they say they cannot breathe very good. But later, when they have the CT, they have no pneumonia. So in some cases, they take these patients to the hospital. In this case, it was very good. The patient was only treated with paracetamol and was only 3 days in the hospital. It was a case in Italy. So, and now that was my whole cohort, and only the 3 last slides to remember about the ocrelizumab. In ocrelizumab, one of the side effects, as you know, are the infections. But when you look in the OPERA study, they were very there was some infections more when you compare with the interferon. But when you look in the primary progressive MS study, the number of infections for ocrelizumab and for placebo was really very, very similar. But what's important thing, when they have done some analysis with the OPERA and oratorio study, they say that severe infections, there are very few. And when the patients, they have severe infections, most of them, they are bacterial infections. There are very few, as you see here in the oratorio study, they were not viral severe infections. So that the most of the patients, when they have a severe infections in patients treated with the ocrelizumab, they are bacterial infections and not viral infections. And as probably you know, there is one study, the name is Veloce, and in this study, the objective was to investigate the effect of ocrelizumab on the humoral response to some vaccines of the patients. So there was a study that they have decided to see how the patients that they are treated with ocrelizumab, how they react to different vaccinations, and to see if the vaccinations are in these patients, they are effective, they have a benefit. So that they have looked all the different vaccinations. I will only show the influenza vaccination, but could be similar to the coronavirus vaccination. And as you see here, there were patients with ocrelizumab, and they are the control after the vaccination. And you see the patients with ocrelizumab, they have enough humoral response, they have enough humoral immunity to respond to the vaccination. That it means that in the case that you have a vaccination of coronavirus, or in this case there was the flu vaccination, the patients, they will react. And the other important thing of this study is that the patients, when there is some virus, they have enough humoral immune reactions to fight against this virus or to fight against this bacteria, so that the patients with the ocrelizumab, they have a small decrease of the reactions, but they have enough reactions to react against bacteria and virus. So, and to summarize, the last study, that is to summarize, is that the patients with ocrelizumab, they have enough humoral response to the vaccines and to the antigens. And these patients, they can have vaccinations when they need. And when the patients, like they receive influenza vaccination, as was the case, these patients, they will have a protective humoral response. Thank you very much.
Thank you very much for very interesting and very useful information. I think questions will come at the very end of our session. And now I'm very happy to give the floor to Professor Khachanova, who will be speaking about the Russian guidelines for management of COVID-19 patients and what to do with DMT. Well, thank you very much, Marina Mafaevna. Thank you very much, Sylvia, for this very interesting presentation. When I was preparing my slides, I also want to cover particular issues related to the vaccination. I hope it will be very interesting for us. Yes, truly, by now, we have many questions about the situation with MS, whether these patients have higher risks to get infected by COVID-19, and then the other questions related to that, with the expected design of anti-COVID vaccine, and how high is the probability that MS patients will give a proper humoral response to the vaccination. So I would like to say that those of you who were part of our webinars before, you already saw this chart, very busy chart, which was actually designed by British neurologists. And this is COVID-19 pandemic and the use of MS disease-modifying therapies. And there were some changes to this chart, and Gary Giovannoni was the initiator of that. And here you can appreciate innovations. First innovation is that alemtuzumab and cladribine and methoxsantron somehow became a part of low and very low risk. But again, he is appreciating the products only in the situation if the patient already has immune reconstitution, not when the patient has received just first cycle, no matter cladribine or alemtuzumab, but when immune reconstitution already took place. We know that immune reconstitution requires specific time. That is why we cannot immediately expect that immune reconstitution is not happening. So patient already restored particular response at a proper level. And the second interesting thing is the probability of releasing response to the vaccination, if there is any vaccination. And you see that interferon beta, according to the author's position, it does not influence to the demonstration of response. The same is about alemtuzumab and cladribine, if such immune reconstitution took place. So what could be the confirmation of that? First, back in 2013, multi-center international study was carried out in the 3 parallel groups, and they influenced the immune response, and they studied it. So there were 2 groups of patients who received teriflunomide first in the main study, in the pivotal study. That was 41 patients who received 7 milligram teriflunomide a day, and 41 patients received 14 milligram of product a day, not less than 6 months after the completion of the extended phase. And then they continued. There was one more extension, and the third group were MS patients who received interferon beta not less than 6 months. So all patients were vaccinated against seasonal flu with strains of H1N1, H3N3. And you see that the primary endpoint was the percentage of patients with titers of specific antibodies to the flu strain more than 40 days after, more than 28 days after the vaccination. So the outcome was very positive. You see very high percentage of patients, up to 97% was the patient rate, who had sufficient antibody titers in 28 days after the vaccination. So, and the authors concluded that here there is no reduction of antibodies after vaccination in case of this treatment. So, and if the patient is vaccinated anti-COVID vaccine later on, then there is a good chance that the patient will be able to provide the response. Alemtuzumab, we know that this drug is actively used, and in 2013 there was case control study, and here they assessed immunocompetence in 24 patients after alemtuzumab treatment, and they measured antibodies to 3 vaccines. So there was diphtheria, tetanus, and poliomyelite vaccinations that were studied, and also a conjugate vaccine of Haemophilus influenza type B and meningococcus group C. And in 20% of patients, antibodies to the prevalent viruses, which is smallpox, chickenpox, measles, and Epstein-Barr virus. So they measured it before the start of alemtuzumab, and then in 1 and 9 to 11 months after the start of treatment. And then they compared the results with historical control. What was the result of this pilot case control study? The investigators showed that all patients had seroprotective levels of antibodies to diphtheria, tetanus before and after vaccination. So that was important that the share of seroprotective patients increased after the vaccination, both against Hep B and against meningococcus. And the authors had a very cautious conclusion that after the treatment of alemtuzumab, there is preserved capacity to have antibodies against diphtheria, tetanus, and poliomyelitis based upon GMTR data. We know very well that repopulation of lymphocytes after alemtuzumab may look very differently. That means CD4, CD8 cells are slowly restoring after each cycle, but it happens slower than the B cell repopulation. CD19 normally reaches initial levels in 3 months after alemtuzumab, and in some patients, repopulation is having this hyper effect, and this is probably secondary autoimmunity. CD4, CD8 cells are restored much slower. Here you can appreciate that average rate of CD8 by month 9 reaches 230, and the lower level of norm is reached by month 12 after treatment, and in some patients it takes even longer time. That's why it tells us that only in case of complete reconstitution we can expect that the patient will not have lower response to the infection, so the patient will be able to resist and will be able to get antibodies if vaccination is carried out. And CD8, as you see, that upper limit of norm is reached in 8 months. So it's important when we speak about vaccination, we do believe that immune response is mainly associated with CD8 T lymphocytes. So those patients where there is very strong deletion of this pool of cells, definitely the response is slower, and they do not respond very actively to the vaccination. Next group of products, which is actually presented in the Association of British Neurologists, you see, so dimethyl fumarate, so with extended scheme of dosing, and Sylvia just told us that they try to switch patients to the extended interval, and ocrelizumab is also here, although it has multiple positive effects, but here, in response to answer the vaccination, and dimethyl fumarate, if patients do not have strong lymphopenia, so probably there will be no influence of treatment to the production of the response, and the same to the natalizumab and ocrelizumab. So this is glycoprotein of the vaccine, because this is protein containing, and most probably in order to prepare the vaccine against SARS-CoV-2 would not be easy because it should be glycoprotein vaccine, and live attenuated vaccines very difficult to produce when it is related to glycoprotein. And correspondingly, a very important add-on which we should know about ocrelizumab. Well, we know the advantages. We know that ocrelizumab is influencing B lymphocytes CD20, and also you know that about 20%, this is a reduction of CD4, CD8. That's why possibly we will have more prolonged release of viral shedding if patient is infected. And one more publication on the immune response to the vaccination of those patients who are getting dimethyl fumarate. As you can see, that was open multi-center study, and the patient received 3 vaccines, also tetanus, diphtheria, and ataxin for the testing of T-cell dependent response, and polyvalent conjugate pneumococcal infection in order to assess T-cell dependent response. So 3 vaccines: tetanus, diphtheria, pneumococcal, and meningococcal. And age of patients was from 18 to 55, and this is pegylated interferon 1 alpha is about 3 months, or dimethyl fumarate. So that was the baseline treatment. So they analyzed the share of patients who had doubling of IgG against tetanus before the vaccination and after the vaccination. So what was the outcome? It is presented here. As we can appreciate, with dimethyl fumarate, we still have very good immune response to all types of vaccines that were introduced to the patients. The share of patients who are doubling definitely is the higher than the share of patients where there is quadruple multiplication of antibodies. And here you see individual antibody titers. And the most important, that the share of patients with protective immunity was high enough. But we should not forget that within the first year of treatment, dimethyl fumarate, we about 30% reduction of lymphocytes. And unfortunately, we do have patients who have very resistant leukopenia, especially up to 0.5, which is considered to be critically significant due to the association with multifocal enteropathy. So the other publications show that if we stop DMF to the patient's dimethyl fumarate, then there is a very long process of lymphocyte restoration. And then this effect as lymphopenia is seen on CD8 lymphocytes. And as I said before, those patients who are not very long, up to point A and even 0.5, but less than 6 months. So they're slowly restoring their immunity, and the level of lymphocytes is reaching low level of norm within 8 to 6 weeks. So this is the right side of our slide. So those patients where within 6 months we observe the resistant lymphopenia 0.5. So it takes them too long time, very long time. So it can be about 1 year. So we have to keep it in mind, and we have to understand when we make particular decisions on the dimethyl fumarate. So whether it should be slowing down or continuation or discontinuation of this treatment. The average risk, according to British neurologists in fingolimab and natalizumab, with the standard interval of dosing, and here cladribine is also here, that possibly disorders a response to the vaccines, but as for British colleagues, it has moderate risk because lymphocytes are still restoring. And another study, phase 4, and this is influence of natalizumab to the immune response after the vaccination. So there were 2 groups of patients. They were randomized, and one group was control, and they were just immunized, and the other one, after immunization, received 6 months natalizumab, and 30 patients in each group, and both groups were vaccinated with tetanus and endotoxin, TD, and then 3 vaccination of KLH, split into weeks. And they had absolutely similar response in control group versus active group. And the authors concluded that natalizumab treatment most probably does not have any clinical significant influence to the immune response, neither for the primary or the secondary immunization. It is important to say that we used to speak about leukocytosis with natalizumab monotherapy, but if we appreciate its influence when we perform long-standing treatment, subtypes of lymphocytes, we see that both subpopulations of T cells are increasing, and the ratio CD4, CD8 is not changing dramatically. At the same time, the B lymphocyte rate is increasing dramatically versus T lymphocytes and natural killer cells and NK cells. Selective depletion of T and B lymphocytes can happen with cladribine, and we know that for cladribine activation, it needs to enter the cells, and enzyme activating cladribine is actually in TB lymphocytes. That's why there is depletion. That is why we have this depletion of B cells mainly. So you see CD19 reduced by 70-80%, whereas immune T cell immunity is not so damaged in this situation, and reduction is lower. And the restoration of B cells happens faster than CD4, and the median of lymphocytes is coming back to normal range, sometimes up to 30 weeks from last dose. So this is also important. That's why we are saying that in some patients who received already first cycle of cladribine, probably we should not be hurry with the second one, especially now in the period of pandemia. And also, what is also high risk, our Western colleagues believes that mitoxantrone as and also cell transplantation. Let me demonstrate metoxantrone and other drugs' influence. And this is a study which was carried out in 2014 in Norway in the University Hospital of Haukeland in Bergen. So 113 patients in 2009 and 49 patients in 2010. So they were all invited in the swine flu pandemic to the study, and then later in 2010. So 113 patients participated in 2009 and 49 patients accepted to pass through another vaccination. So again, during pandemia in 2009, patients were vaccinated against swine flu, H1N1, and in 2010, there was three-valent vaccination against seasonal influenza. It's either H1N1, H3N2. So the authors showed that those patients who received metoxantrone, here you see very small percentage of patients could produce protective immunity to the specific vaccines. And as a result of that, they concluded that metoxantrone, if it's done currently, so probability of the fact that the patient will not have immunity would be very high. And now, coming to our tactics and guidelines for the MS patients management, as soon as this trend was observed in all the countries to discuss the problem, how to behave, what to do, um, we know that International Federation of Multiple Sclerosis Patients, they publish general recommendation on their website. Plus to that, British colleagues, British neurologists were one of the leaders. They also published their guidelines on the website. And yesterday I checked, and now we see that almost majority of professional communities, MS professional communities in Europe and in other countries also published their guidelines and their position on the immunomodulating treatment, because as Celia said before, definitely many patients were quite concerned whether they should continue or stop immunomodulating treatment, especially now. There's big concern of those patients who are expecting change of treatment. So me and my colleague, we are actively examining those patients who skipped and missed the Tizabra infusions, because Moscow is now closing for self-isolation and for the lockdown. And now we call these patients for the second examination, the ones who were elective scheduled for the change of treatment, mainly those patients who are indicated acrelizumab or alemtuzumab, in order to make individual decisions. So March 22, according to the position of the Medical Association of the Doctors, and we wanted to carry out a teleconference and provide our position, what we are going to do in the situation of pandemic and how we are going to manage our patients in this current situation. So now I am going to present you the results of our teleconference. First of all, we're totally supporting WHO and all international communities, saying that our patients should follow clear guidelines which are available, which are designed and published. And Russian regulators also approve them, and this is what we need to follow. It is very important to pay attention to the family members, to the relatives of the patients, of those who are caregivers, that currently they also can be the potential source of the infection. That's why they have to follow general antiviral recommendations. For the pregnant women, currently MS pregnant, there are no specific recommendations, and I managed to find only 2 publications that are describing the behavior of Chinese doctors with their pregnant patients, but without MS. And I could say that actually no specific recommendations yet designed by the Chinese. Speaking about the children, MS children, well, we could not find any specific guidelines, and I'm pretty sure there will be no, because children are self-isolated already for a long time. That's why so general recommendations for adults quite applicable for them. So it's very important that all the concerns, doubts, fears about the treatment patients have, which is currently now is receiving or is scheduled in the future, should be discussed with the treating doctor, and don't make independent decisions about the discontinuation of treatment. No discontinuation. What is also very important, what is important is the tactics for the patients who are referring with exacerbations, with flares. I know that in many entities of the Russian Federation, we are all in lockdown, including outpatient doctors and patients. So majority of polyclinics and outpatient centers are not available, not open for the MS patients. So it's very important. So if patient has a suspicion for the exacerbation of the flare, the patient should know where to go or where to call. And mm, then the decision should be made about steroid pulse therapy, and if yes, under what conditions. We believe quite reasonable for such patient to be examined for coronavirus infection, not to worsen the situation with methylprednisone. Side effects. Adverse events, as you know, can be seen with interferons. So patients, they're simply complaining on the headache, and they very rarely use ibuprofen in this case. And there was another publication which suggested that ibuprofen, in this case, playing a more negative role than positive. So we recommended our patients to refuse from ibuprofen and to use just paracetamol. So right now, the WHO seems to not to confirm this information. They believe that there is not enough evidence-based data, but still such recommendation was given. So I was pleased to hear that our Spanish colleagues also minimized patients' referral to the outpatient centers. We understand that this is essential limitation, but we thought about preventive type of such intervention when many hospitals were not transformed into COVID hospitals. We already recommended to all of them to provide electronic prescriptions for 180 days to minimize patients' visits and possible delivery of drugs to patients to their homes. And when we discussed our guidelines, as you can appreciate here, we put specific accents, important axes. So first of all, we looked at the patients from the type of disease, course of disease, then what is the stage of the treatment process. So this is the issue of initiation and continuation of treatment or switch. And last but not least are the clinical aspects. So these are patients who already having infections risks. So at that moment, when we designed our recommendation, the question was whether the patient was traveling or had some COVID plus contact, or patients did not have any risks of infections, or it could be a patient that can get coronavirus at any moment. So we thought that the patients who are suffering from remittent form or secondary progressive. So if the decision is taken about initiation, so we should use either interferon beta or glutamate acetate. And if the patient got infection, so we believe that we can postpone the start of treatment at least for weeks until recovery. If these are patients with fast progressing MS, you know that these patients had multiple threats for early disability. So here we need to be, let's say, fast decision makers. We don't know how long coronavirus pandemic could be. That's why we thought that probably it would be right to consider natalizumab as a drug of choice, but not to start alemtuzumab, cladribine, and others. And only if patient is already infected, then this treatment should be postponed. Patients with primary progressive MS, definitely these are the patients who were waiting for a long time to have targeted treatment. That's why we looked at this situation, and we decided that only patients who belong to group of increased risk, and these are patients who are 55 with particular comorbidities that are increasing risks of severe complications of COVID-19. So to such patients, treatment should be postponed. And for the rest of them, currently, because the drug is available, we can provide first cycle 2 infusions But the only thing is to check the tests, so they should be properly examined and monitored. And if there is any minimal risk of infection or patient already was infection, still we have to postpone the treatment, because you know that depleting effect of anti-CD20 drugs would be very clear in 2 weeks. So this is effect of ocrelizumab. So we decided not to hurry. So those patients where we planned continuation. So in majority of cases, we are supporting. We believe that the treatment should not be interrupted, specifically speaking about interferon beta or glutaramine acetate. Well, teriflunomide, here we possibly can discontinue or to resolve the issues about the restart upon the discretion of the treating data. So we need to provide safety monitoring on lymphocytes and further safety. If this is fingolimod or dimethyl fumarate, well, only in case of critical levels of lymphocytes up to 0.2, then yes, such patients should also be very closely monitored, although visits to the hospital should be minimized. And we totally agree with that. But if the patient is sick and infected by coronavirus, we thought that possibly treatment should be discontinued temporarily. Natalizumab, ocrelizumab, alemtuzumab. Well, about natalizumab, we totally agree with our British colleagues and with our Spanish colleagues. So we recommend to switch to the extended intervals, but only those who already received natalizumab for about 6 months. If patients just started natalizumab, then it should be continued with infusion rate once in 4 weeks until possible. Ocrelizumab, the same story. So patients with remitting or secondary progressive MS who already received their first infusions, and the plan is to get the second one. So if they do not belong to risk group, then we think that such infusions should be done and very clearly show the patients the lockdown rules. Well, alemtuzumab, we also totally agree with our Western colleagues that although in the label we see 12 months in between two treatment cycles, especially first 2 cycles. Nevertheless, we can increase the interval up to 18 months between cycle 1 and cycle 2, because we know that within first year, depleting effect of alemtuzumab to CD4, CD8 cells is really very strong, and their restoration happens very slow. Well, we have another serious group of patients. So these are patients who are waiting for the treatment escalation, who are waiting for the switch. They could be patients who are resistant to the drugs that are using currently. And right now, in the current situation, the drug of choice would be mainly natalizumab. And the patients, those who plan to switch from fingolimod to other drugs. So it's better to continue fingolimod than to start something new. Well, those patients who are receiving first line and they're recommended to switch to the second line, and if there are any contraindications to natalizumab, then it's up to your discretion. So if you decide that any other drug of second line can be started. So if these are patients who are having high risk of the progressive multifocal leukoencephalopathy and they completing or have completed natalizumab, and you scheduled the switch to the other drugs because of that risk. So right now, during pandemic, if possible, please continue natalizumab infusions. So please continue with extended interval, not because of risk of progressive multifocal leukoencephalopathy is reduced, but this is minimized number of contacts, just the only reason. And if you plan to switch to other drugs like fingolimod, alemtuzumab, or ocrelizumab, then we should have very balanced approach right now in pandemic, very well balanced, and probably postpone the onset if it is related to the risk of coronavirus infection. You know that April 19, one more set of clinical guidelines was published. This is management of MS patients in pandemic COVID-19, and this is Rakir's website. So here are 3 groups, mainly 3 groups: those who did not have any contacts with COVID-19, those who contacted with carriers, or those who already have confirmed diagnosis of 19. And here we have particular recommendations for each group. And this is actually a repetition of what we heard before, which was prepared by the medical associations of doctors and centers of multiple sclerosis. So that's it, what I wanted to say. Thank you very much for your attention. And as we are having web chat here, so in the web chat, we are receiving questions. So at the moment, I'm going to read them now. So there was a first question to the Celia. How fast did you manage to organize hotline telephone for the patients, and how many doctors and nurses were involved into the hot telephone line for the patients? Thank you.
So we have always a hotline. So for the normal situations, the only thing that we have done is that the nurse is the whole day with the hotline, so that we are two physicians and one nurse. The nurse has always the hotline, and the other two physicians, we are with other telephones, so that the nurse can always connect to us with other two telephones. The difference with before, that was the hotline before was only used for 4 or 5 hours every day, and now we are using the whole day. So that's the is always working the telephone, and that is coming to a automatic answer, and that's the nurse can hear this automatic answer from other places, so that we can connect with the patients the whole day, not at the night, but the whole day, and see us. She sent to us a message or she called us, and we can answer always the patient. So, but the good thing is that we have a hotline before only for some hours a day, so that the only thing that we have done was to put more hours the whole day. And for the neurologists, we are two neurologists doing all the answers by email and by telephone.
Thank you very much. One more question, Celia, to you. Did you publish any local guidelines for the MS treatment in period of pandemic? And if yes, what's the main idea? Thank you.
So yes, we have published local guidelines because we have seen that the situation was really very bad. So it was very similar what Maria showed. So that they are very similar to the English one. So that's the only thing is when really the patient. The difference is we so that when the patient is really with the coronavirus, so when the patients they are infected, the thing is always we look at the lymphocytes, and when the lymphocytes are low, we stop always the treatment for 1 2 weeks. And when the patients they have no more the COVID infections, we start again the treatment. That is the thing that we put again, because we have seen that was a lot of infected people, and we have seen the first patients with coronavirus and MS. In general, the other recommendations they are very similar. That's Maria show. They are a mixture between the English and the European recommendations. So that we for the first line we don't have problems. We continue everything, and only with the ocrelizumab we delayed some 2 or 4 weeks, depends on the patients. We have, as Maria said before, we look at the individual case. We individualize everybody, and with the Tisabri is the same. We put a 6 weeks for everybody. We have fortunately we have no new treatments in the last 4 months for Tisabri, so that all our patients they were more than 6 months with Tisabri. And I agree with Maria that patients that you need to switch from first to second line, is easier to switch to natalizumab, because natalizumab is easier to manage in the pandemic, because you can always stop, you can start again, and these patients they have a lot of lymphocytes, so that when they have COVID, I saw we have 4 patients with Tisabri. When they have COVID, they have enough lymphocyte, and all 4 patients they have a very mild course, because probably because they have a lot of lymphocyte, and because probably there is some effect in the alpha integrin with the natalizumab, and they do that they have less reaction of the endothel, and they have less inflammatory reaction.
Celia, another question. According to your experience among your MS patients with COVID, MS plus COVID patients, how frequently did you see lymphopenia and how severe was it?
Yes, I have a C lymphopenia in the more or less only 1/3 of my patients. And that was clear, the patients with the fingolimod, because they have a lymphopenia and they have more lymphopenia. And we have only stopped in one that was only with That was the with 100 lymphocyte and 100 we have stopped clear, and we have seen the lymphopenia in the patient that was with in the patient that one of the patients that was with the Ovayo. That was the reason to stop. And from the patients with the Mavenclad, two of them they were with the Mavenclad, where they were with 700, and with the COVID they were in 500. So that really they have when they have lymphopenia is because they have lymphopenia with the treatment, and they decrease only a little. So that we have seen decreasing only from 2 or 300, not much. Probably because they have, and the patients that were without lymphopenia with interferon, with Tisabri, they have no lymphopenia with the coronavirus.
Maria, the question to you, what about patient journey in Moscow now? Patient journey, as Celia said before, this is the same principle. So if patient is stable, patient should stay at home. So the only journey is to stay at home, not to get coronavirus, because they already have some treatments and now they can get prescriptions for 180 days. So please stay at home with 180 days stock. So we kept only daycare units, just like I see in Spain, daycare for emergency. For those who continue IV treatments, that means we have Tizabri in extended regimen, we give ocrelizumab, but again, depending individually, if there are some specificities, then in the correct regimen or with extended interval, and we stopped the onset alemtuzumab. So the first infusions to all, we postpone all of them until this pandemic is reduced. So right now they're all on hold on, and they're getting just methylprednisone instead of their dedicated treatment. So IV methylprednisone. If this period is too long, maybe we temporarily offer something else until we are able to start alemtuzumab. But in principle, I actually totally agree with Celia. Our trends look very much the same. To stay at home, that's the biggest journey. Please do not visit clinics or outpatients. Don't visit medical institutions or centers for tests or whatever, not to be infected COVID. Please receive the treatment that you are already adapted to, and all questions about the switch should be postponed to a later period, let's say better period, a resolved period, when we have more or less resolved situation. I don't think that pandemic would be endless. So one day it is resolved and we will be able to restart. So we have the same trends with Spanish colleagues. So the most important to keep these patients, to preserve them, and to avoid infection in our patients. And then we will manage. MS is better story than COVID. Yes, for sure. And another question. So what do you think about home injections at home? Well, home infusions. Well, what is allowed to do? They can do it. They can do it sub-Q and intramuscular, and to take tablets. This is what they can do. The other types of treatments are not allowed for home administration, and we are not using them. So if the patient is developing very severe flare, and for these few days while we are working in a very narrow windows, we had patients, we had pregnant patients with flares, we had other cases. Definitely we resolve these issues individually about hospitalizations into so-called clean hospital yet clean, and then to provide Solmidrol. So no monoclonal antibodies, no hormones at home cannot be done. It is completely prohibited and it should not be done. Thank you very much. Celia, another question to you. What did you do with clinical trials? Do you stop? Do you continue? Do you postpone protocols, clinical trials, protocols?
Yes.
Keep in mind now you are COVID plus hospitals. So what do you
Yes.
do with trials?
Yes, so that is a very good question. So we have a lot of trials. We have 15 clinical trials, so that we have studied every trial. Yeah. So the trials that was with oral treatments, they were not very difficult. So that we have done telephonic visit. We have given the patients the medication. We have sent the medication at home, and for the patients that we should do really a completely examination, we have used this clean building that is far away from our hospital, this clean outpatient building. And so that we have done only there the most important visits. Normally, this visit that they are long visit that you need to do EDSS and all these examinations. So for these patients, we were in the clean building, far away from our hospital. We have measured the patients the fever before, and we were with mask, the patients with mask, and we have done the examination, the EDSS, and all the scales. All the things that we could do by telephone, we have done by telephone. All the patients they have received the medication at home, and for the IV, for the studies that they need IV, or for example, we have one thing with subcutaneous that should be in the hospital. We have still doing in the hospital, in our day hospital, with all the precautions. The patients they sit very far away with mask. We take fever, and for one study that we have with ofatumumab, we start now to put the injection at home because that was subcutaneous. We spoke with the company and we can do up the subcutaneous things at home, so that we send the patient the subcutaneous medicine at home and they can do by alone. So that we have transformed something, so that we don't do every visit in the hospital, so that we try to do in this clean building. And some of the visits that they were very short, we have done by telephone. The only thing is the blood examination in some studies, when they were not really compulsory, when they were not really because of a risk, we have not done. In the studies that was really compulsory, the blood examination, and was because of the risk of the medication, we have done in the clean building that we have. It's always important to have a clean building. Perhaps in our case, it's far away, it's 10 minutes far away by car, but we prefer to go there, and we prefer that the patients go there to have a place clean that we can perform some things.
Very much. Celia, I would like to comment on that issue with our reality. Yes, in Moscow, we face this challenge as well. But due to the fact that the sponsors of majority of trials, they understand the challenge and how to do it, how to stick to the protocol in the current situation. So all those products that are patients in the trial and that does not require hospital administration, they will receive them at home, and they will do it at home, or maybe from the depot of sponsors company, or maybe a third party, the distributor will send it to the patient's home. About the tests, well, all the companies accepted current situation, and they made agreements with the third-party laboratories. So patients can be sent to these laboratories, or sometimes even mobile teams can come to patients at home and to take blood tests. And the only question, let's say difficult question about infusion IV forms, in one of the options, we switched patients temporarily to the other centers that are allowed by the Ministry of Health to be centers for the trials, and they're not infected by COVID, and they can do the infusion. And as soon as the situation is resolved and our center is relaunched, our patients come back. So yet all sponsors, all companies, they have very good understanding, very well-balanced approach, and they understand that each day new hospital is closed and switched into COVID, and actually each day we were waiting that our center is closed, and we wanted to infect our patients. Maria, there is a question to you. How long do you give Solomitrol to the patients who cannot start alemtuzumab after natalizumab? Bridging. How long is bridging? Well, yet our experience is very limited. We started switching these patients, well, maximum is 4 months. We don't have longer. We don't have longer bridge. And now yet it is a question what to do. Either we administer something else, let's say, Giovannoni method, which is something additional, let's say first line, temporarily first line, with further switch to alemtuzumab, or if the test is good and if we find the so-called clean site, then we will be able to make this infusion. So yet we don't have longer than 4 months. So not longer than 4 months yet. 4 months of bridge from the end of December. There is one more question to me. When did you perform the vaccination to the patients? I mean, in the clinical trials, before the start of treatment or after start of treatment? I would like to emphasize the design of the several trials required that the patients were already on treatment by one of DMTs, and before they were enrolled into the study, they first had to be vaccinated, and then immune response was tracked, or it was requirement at the start of treatment, we first vaccinated them, depending on the protocol. Then they received investigational products for about 6 months, one of them immunomodulators, and then it was either revaccination or the antibody test. So depending on the protocol. So main trials wanted to see whether duration of treatment and the treatment itself influences the capacity of immune response to vaccination. Another interesting question in the chat about interferon beta 1b. Why it's not in our guidelines for the primary patients? Because we can see it in the guidelines in the Ministry of Health. I would like to emphasize, as a primary patients, where we plan initiation of the treatment, and we actually can say that this is gluteramine acetate or interferon beta. But the only thing we wrote that if this is coronavirus positive patients, corona plus, then we do not recommend to start treatment right now. But when we discuss these recommendations, interferon 1 beta B was not yet approved by the Ministry of Health. It is very fresh recommendation of the Ministry of Health. Now I know that interferon beta 1b is in the list of the Ministry of Health, and probably infectionists will make the decision, but not us neurologists, if they have MS patients who is yet on treatment, but already with corona. So that means DMT minus but corona plus, and I think that should be the decision of the infectionists. If patient is not infected, that's exactly our option. Another question about ocrelizumab, how ocrelizumab can possibly influence T cell population through which mechanism? Yes, it was very interesting to see the results of Opera 1 and Oratoria. They showed that T lymphocytes also reduced with ocrelizumab. The only then in Opera study where was comparison with interferon beta 1a, so T cell reduction was not as strong as with interferon, but in Oratoria, in comparison with placebo, the reduction was much stronger than with placebo. One of the possible explanation of this reduction is that CD20 receptors could be seen not only in B lymphocytes, and yes, there are subpopulations of T cells that also have CD20 antigen on the surface, and that is why ocrelizumab potentially can reduce T lymphocytes as well, but much lower than with B lymphocytes. Celia, question to you. What are the most important tips and tricks you can share to the doctors all over the world, those who are not yet reached the peak of pandemic? Tips and tricks with COVID. What would you recommend to all of us?
Yes, so I will do first. I would like to do a comment about the interferon. We want at the beginning of the pandemic, because the good thing is when you are now starting, you know more, because we have begun 2 months ago, yeah. So we have started to use interferon beta in patients with coronavirus positive in the hospitals, yeah, because this study, and in patients with MS and coronavirus. But our colleagues from the internal medicine, they told us the problem with the interferon is the interferon you need more weeks to have an effect. And the coronavirus is an acute infection, so that they have decided not to use more. So they have used at the beginning a lot because of the study from the Chinese people, but now they have decided not to use because they say the effect is too long. They start 1 month later. And the second thing, because of the interferon, the patients, they have more headache, more fatigue, more fever, because of the flu-like, so that they don't know if the flu-like is from the fever is from the flu-like or from the COVID. So that is a little, they thought is complicated. So that's now they have decided not to use more interferon for patients that they have coronavirus positive. After 1 month, yeah, the first month we were using, but now we are not using more. So the tips and the tricks, I will say, the first important thing is, as Maria said, to stay at home. So the most important is because there is a problem when you are at the beginning of the pandemic, you can manage everything. But when you have a one moment, many patients at the same time, that all of them they are infected, you cannot treat all of them, and that is the problem. The problem is that you cannot treat so many patients at the same time in very few days. So the most important thing that we say to all the patients is the same of MS or not, is to stay at home, always to wash the hands a lot, and very important to have the mask. I don't know if you remember at the beginning, the World Organization, the health organization say not to use the mask, but was because we were not enough, we have not enough mask. And we see now the most important thing is to use the mask, because when you use the mask, the physicians use the mask, the patients are using the mask, you are avoiding infection. So that I think is one important thing always, that everybody try to use a mask to protect him, to protect the person, and to protect the other patients. And related to MS patients, I will say not to stop the treatments. Always, in the case that you need to switch, or you have a patient with coronavirus and MS, always to speak to the neurologist and to decide, because in some cases you don't need to stop the treatment. When it's a mild course of the coronavirus disease and the patient has enough lymphocyte, you can wait. And when you have, for example, a first line, you can wait. And when you have, for example, Tisabri and you are between two infusions, you can wait. So that was our situation. A patient has Tisabri, 1 week later they has the coronavirus infection, and you have enough time to put the next Tisabri. So that I think it's important to individualize the patients. For the first line, I don't see a problem. For the second line, it's better always to look at the patients and to look at the lymphocytes. And really very important to avoid, as you said before, to minimize that the patients are coming not to the hospital, to the GPs, to everywhere that they can have a risk of infection. Because the big problem is that the hospitals, the outpatient consultations, the GP consultations, they have a high risk of infections, because they have a lot of patients with coronavirus, and that is the big problem. So that for us was clear: protection, a lot of wash of the hands, and a lot of these disinfections of the patients, of the hands, and stay at home, I think, is the best thing. And for our patients, the problem is now our patients, they at home more than 6 or 7 weeks, and many of them they complain they are not given, they are not having rehabilitation. And so that we have recommend all these patients to put at home YouTube, or to put videos or something like that, and to try to do at home yoga, or some kind of a sport, because it's very important for patients that they have progressive MS, or that they are with an EDSS of 4, that they can have some movements. So that they will say, please put a video, put YouTube, put something similar, and you can try to do some exercise, because 1 week is okay, 2 weeks is okay, but when you are in the week 6, the patients, they say they can walk worse because they are not moving.
Yes, this is very clear. Celia, thank you very much. We are behind our schedule dramatically, so our time is extremely limited. So let me ask a final question. This is question about metoxantron. The question is, if we are planning infusion 4 of metoxantron, no lymph and leukopenia, can we do metoxantron number 4 in pandemia? I would say I would postpone. Not because of lymphopenia is absent or leukopenia is absent. Yes, most probably reconstitution already happened, but one thing, if we speak about metoxantron in the medical history, so we may not be concerned that previous infusions would somehow influence, but if you plan it now, this infusion, then within next month, you again will initiate lymphopenia, leukopenia. So again, increased risk. So I believe if clinical situation allows you to postpone, I would postpone. Celia or Maria, do you have the different position? Well, I think this is a good solution. I would postpone as well.
Yes, I will do the same. I think is in this moment when you have an increase of coronavirus infection, I will not do. I will wait.
I would like to say that we covered almost all the issues we planned and we answered the majority of questions. So from my side, I'm very grateful to Celia for her time, for finding time in her busy schedule, and she accepted our invitation very shortly, in a short notice, to participate in our webinar. Thank you very much, colleagues, for your time that you invested to be a part of our discussion, to listen to us, to provide your questions. And I'm very grateful for your work and for your time and attention that you're devoting to your patients. Yes, from my side, I also would like to express gratitude to Celia. Thank you very much for being with us today with the discussion. It's very interesting for us because your experience is much bigger than our experience. We just start entering the stage you are already adapted to. So this is very useful for us. Thank you very much for your information, for tips and tricks. And I do hope that all together we will manage this new infection. Stay healthy. Stay healthy. That's the most important. Thank you very much.
Yeah, thank you very much for the invitation. It was a pleasure to share the talk and the panel with you both. Thank you, and thank you for the invitation.